and still going with the major topic, breast cancer. And next session will be about early breast cancer. And we are going to discuss regarding the experts and updates in early breast cancer.
Dear professors and colleagues, I have the honor to present Professor Hamdi Abdelazim, one of the most eminent professors in Egypt and in Sharq al-Awsat, who will present treatment escalation in hormone receptor positive, HER2 negative early breast cancer.
Thank you so much for the chair lady. Thank you. And of course, my thanks extends to Dr. Lubna. I congratulate her for having this conference and for having the responsibility to chair the whole department of clinical oncology in Shamsi University, one of the major cancer institutions in our country. I was giving the job to how we think about treatment escalation in hormone receptor positive HER2 negative, and here's my disclosure. So we'll start with the very beginning. What's really unique about hormone receptor positive HER2 negative early breast cancer? First of all, as the name implies, it's hormone receptor positive. So the estrogen receptor mediated cell growth is a fact in this kind of tumors. So endocrine therapy evolved as the main therapeutic adjuvant treatment modality. It's the main, not one of the main. It is the main treatment. And if you don't believe me, look at this. This kind of improvement in the recurrence-free survival and overall survival, you do not achieve by any other category of drug. Not by the best anti-HER2 you have at the present time. Not by the chemo plus immune therapy in triple negative. You do not have this kind of improvement. So it is the most important and the most realistic tumor. And hence it comes that the meaning of my presentation, why the organizing committee, they chose to give me this title, because we know that they respond to chemotherapy, but it's not a wow response. It's not very impressive. And this is one of the many studies to tell us that if you give neoadjuvant chemotherapy, the best PCR rate will be seen in HER2 positive and triple negative breast cancer, while the yellow lines, they are luminal A and luminal B. Of course, luminal A is very modest, luminal B is better, but still modest. So it's not really impressive that you give chemotherapy to this patient, and you need to understand how we can really utilize chemotherapy in this patient. Thirdly, which is, if you think that by 5 years your job is done and your patient is doing fine, unfortunately don't have this confidence, because as you can see, after finishing the 5 years of adjuvant endocrine therapy, and if your patient is disease-free at that time, and according to the TN stage, you can see that the rate of continuous relapse up to 20 years is pretty high. So that's a bad news, of course. So let's focus for the most difficult question. Response to chemotherapy is variable, but generally not quite impressive. Because of that, actually, we have to think about the role of genomics, better selection platforms. Genomics for ER positive to negative breast cancer was introduced around 20 years from now. And it was first introduced as a more accurate prognostic factor to be better in terms of accuracy, better than the standard clinical pathological parameters. And in no time, we started to think, why not to use them to predict the benefits of adjuvant chemotherapy? If you treat by endocrine therapy, then who will need the adjuvant chemotherapy then? We have plenty of essays. Of course, we don't have time to comment on all of them, but importantly, we have to know that they are not the same. The genes involved in each and every one of these platforms, they are not the same. Although proliferation genes, they are common driving force in all the genes. So all these gene expression profiles, you will find a lot of overexpression of proliferation genes. That's a very common point, or probably the most important common point between the essays of gene expression profile. I will only focus on Oncotype DX because I believe it might have some superiority compared to the other essays, although, of course, it suffers from some caveats. How it was developed, actually. It was developed by doing gene expression profile of thousands of genes, and then to compare the expression of these genes with the prognosis of early stage breast cancer patients, ER positive to negative, treated by tamoxifen. And the genes that were really significantly associated with the prognosis were genes related to proliferation and estrogen expression. So these are the major genes that play a role in the prognosis in this platform. You have other important genes, top of the list, the HER2 genes and the invasion genes, but their contribution, as we're going to see, is much less. Anyway, the bottom line with the expression of these genes with very complex bioinformatics, which we should not know, then you will have this kind of equation, and of course we cannot do it. So the service producer will do you the job to give you a figure which is called the recurrence score. And if this recurrence score is less than 18, it is low risk. More than 31, it is high risk. Between them, it is intermediate risk. Then we have to do the exercise and try to validate this kind of information. And the first thing to know that proliferation, if the expression of proliferation is high, then this will bring the recurrence score higher. And if the expression of the estrogen genes is high, this will bring the recurrence score lower. So these are the most two important set of genes. One will bring poor prognosis, which is proliferation, and the other will bring good prognosis, which is estrogen expression. Let's see the outcome. How does it look? That's the first data set published in New England Journal more than around 20 years ago. And it would show that if you do this kind of gene expression profile by Oncotype DX, then you segregate your patients in a beautiful way to low-risk population, intermediate-risk population, and high-risk population. And automatically, without being a researcher in breast cancer, when you see the right curve at 16 years with only 8% they have distant relapse, you tell yourself, this is an excellent prognosis. With endocrine therapy alone, why should you give chemo? Don't need chemo here. But if you see in the same population, but they have high recurrence score, the prognosis is very poor, the white curve. With endocrine therapy alone, then you see, well, endocrine therapy cannot be enough in these patients. I think we need chemo, but we're not sure whether if you add chemo, the patient will benefit or not. Then this was addressed in a second study that had the NSBP. You know, the NSBP is a big group in US. They are involved in the early breast cancer clinical trials. Once upon a time, they were the most important in the globe, but now they are not as solo players in this area. Anyway, that's one of the studies in it's a positive and not negative early breast cancer patients, more than 1,500 patients to receive tamoxifen or tamoxifen plus chemotherapy. And if you can see that the green curve is tamoxifen at 12 years with no chemo, the prognosis was very good. It was around 85%. So already tamoxifen is doing a very good job in this population. And if you give chemo, there is a significant improvement, 5% higher. This means what? This means that you need to treat 100 patients in order to get the benefit only for 5, while the other 95% of the population, they don't need your treatment. So, in order to see whether Oncotype DX can help you in this dilemma. The investigators brought the paraffin blocks of around 600 patients in this trial, and they segregated the patients whether they have low risk, intermediate risk, and high risk, and tried to see who benefited from chemotherapy in this trial. You can see patients with low risk or intermediate risk, zero benefit of chemotherapy, while patients with high risk, they made the maximum benefit. So the data was extremely impressive, but the main caveat was the number of patients was small. The study included only 600 patients. So this needed to be revisited, as we were going to see in a while. For those who do not work in this field, the result is shown in a bit of an unusual way. The x-axis is the recurrence score, and the y-axis is the rate of distant recurrence at 10 years. And you can see that if your patient had a result of 10, the recurrence score result of 10, the likelihood to have metastasis at 10 years is less than 6%. While if it is 25, the likelihood to have metastasis is 16%. So certainly, if you have the green curve, if your patient is in the low side, certainly you don't need chemo. And if it is higher than the red side, then certainly your patients will need chemo. So the problem in the majority of patients who will have a recurrence score from 10 to 25, do they need chemo, yes or no? And here it came the TAILOR-X study, node-negative, ER-positive, HER2-negative breast cancer. Already we know that low risk do not need chemo, so they were treated without chemo. And the high risk in red, they do need chemo, so there was no randomization of endocrine therapy alone. The dilemma in this TAILOR-X study was how to compare the majority of patients with the intermediate risk between 11 to 25, chemo plus endocrine therapy or endocrine therapy alone. And that was published again in the England Journal 5 years ago. And you can see that in the overall population, you can see that with chemo at 5 years and 9 years, whether you are chemo to endocrine therapy early or late, no benefit practically from chemotherapy at all. So don't give chemotherapy. Now we have a data set of more than 6,000 patients, so believe the data. But what is not good here, if you wish to be more specific, is to see that even for score 10 or less, the relapse at 5 years was 6%, but 9 years was 16%. So this means what? This means that the Oncotype DX cannot really predict late recurrence. It can predict early recurrence rather than late recurrence. And this applies also for patients with high score who receive the chemo plus endocrine therapy. After only 4 years of follow-up, you are losing a lot of patients. So this should be taken into account. For the young women in the same study, the situation was not the same because you can see that patients with 16 to 24 or 21 to 25, remember in the postmenopausal, no benefit from chemo, but in the premenopausal, we have a benefit of chemo. We can discuss the reason. But again, the late recurrence is not predicted. So the TAILOR-X and Oncotype DX, the whole story. If your patient is postmenopausal, chemo has no benefit for recurrence score from 11 to 25. That's a finished story. Chemo benefit in women 50 years or younger with recurrence score 16 to 25. Below this, you don't need chemo. For recurrence score 0 to 10, distant recurrence is pretty low by endocrine therapy alone, so you do not need chemo. For patients with 26, anything higher than this, still you have significant recurrence, late recurrence. So Oncotype DX does not predict well delayed event. That's not the author's conclusion. That's my conclusion. For the postmenopausal with 1 to 3 positive lymph nodes, again, do they need chemo? The answer is no. That's the postmenopausal endocrine therapy alone versus endocrine therapy plus chemo, no benefit at all. So the same, what we applied in postmenopausal with node negative, you can apply for patients with 1 to 3 positive lymph nodes. And again, what we applied for premenopausal women in node negative, you should apply in patients with 1 to 3 positive nodes because all of them, they benefited from chemotherapy. So for patients with positive nodes, 1 to 3, in premenopausal women, you don't need to do Oncotype DX because actually, if he is having 1 to 3 positive lymph nodes, you have to give chemotherapy anyway. Now, that's the recurrence score estimation for node negative 1 to 3 positive lymph nodes. You can see it is like this. But what about 4 or more lymph nodes? Don't be amazed because it is very high. So whether it is low risk or intermediate risk or high risk, your patient will relapse. So you have to think differently in this area. By endocrine therapy, you have recurrence of for the low risk of 40% at 9 years if you don't give chemo. So therefore, chemo is recommended in all cases. You don't need to do Oncotype DX or any similar assay because the prognosis is very poor. But the question is still valid. Do these patients will benefit? Would they benefit from chemo? We don't know. But we give them chemo. We don't have data for more than 4 positive lymph nodes. If they have low recurrence score, do they benefit? But we give them chemotherapy anyway. So chemotherapy escalation, that's part 1. All patients with not the positive, more than 4 in postmenopausal women, not 0 and not 1 with recurrence score 26 or more. Premenopausal, all cases with N1 to 3, you don't need to do Oncotype. Premenopausal, not negative, you need to do Oncotype. If it is 16 or more, you need to do chemotherapy. But what if you don't have access to gene expression profile? Because we know in our country, a minority of patients will have this access. So you have to work as an oncologist. So you have to allocate your patients into either luminal A-like or luminal B-like subtype with the kind of histopathological data you have, and that's why the importance of the pathologist in our team is as important as any other one, because she or he will tell you whether it is PR negative or positive. PR negative, the prognosis for give chemo, consider it luminal B. If it is grade 3, consider it certainly luminal B. If it is grade 1, consider it certainly luminal A. But the majority of our patients are grade 2, unfortunately. For the PI, if it is up to 20, less than 10 or 10 to 20, it looks like they are the same. So at the cutoff of 20, you can give chemotherapy according to this data. That's in postmenopausal women and exactly the same data in premenopausal women. The PR positivity, the tumor grade, and the PI more than 20%. That's the best thing we can do at the present time. In spite of all your chemo escalation or no escalation, endocrine therapy, and bone modifying agents, still we lose between 20 to 40%. They will relapse in spite of what we do. So we need to further escalate in a more of a focused way. That's to say how we select our patients to receive the extra treatment beyond what we discussed with each other now. To define the high-risk patients, actually, there is no definition. I'm sorry. We don't have a uniform definition of who is the high risk, but we have a lot of factors related to the tumor burden, related to the tumor biology. There's too many. So for the tumor burden, of course, we know that after adjuvant chemotherapy, you can see that patients with node 4 or more, they have very, very high risk of recurrence during the first 2 to 3 years. Very critical here if we have this high tumor burden. Same happens in triple negative breast cancer, but triple negative cancer, they stop relapsing after year 8. After neoadjuvant chemotherapy, the prognostic effect of PCR and residual cancer burden again is different in triple-negative breast cancer, where everybody is focusing. Actually, we know that PCR is doing great job. Residual disease, if it is mild or moderate or severe residual disease, the prognosis significantly is different. While in luminal disease, the situation is totally different, where residual cancer burden 1 is equivalent to PCR, and the percentage of them is much less. The majority in luminal disease, they have residual cancer burden of 2 or 3, but the prognosis is not as bad as the triple negative. So you have to put that when you try to forecast for the problem of relapse in the future. So in the clinical trial, we have 2 studies that put certain definitions of high risk. The MONARCH study, MONARCH-E study, they put it on anatomical stratification, more than 4 positive notes, or if it is from 1 to 3 positive notes, you have to have at least one of this. Either tumor size more than 5 or 5, histological grade 3, PI more than 20. In the Olympia, they include the patients with after neoadjuvant chemo, so they have no PCR with clinical and pathological stage and ECG grade more than 3 or 3, or after adjuvant chemotherapy, 4 positive lymph nodes. That's how they define. This does not mean that we do not have other patients with high risk of relapse. Let's see the MONARCH. The MONARCH is a beautiful trial, is a good piece of work actually. Abemaciclib, after you finish whatever you want to do, surgery, adjuvant chemo, radio, and then start endocrine therapy plus or minus abemaciclib. And the primary endpoint was disease-free survival. And we were very happy to see this, that is at 3.5 months, you have an absolute gain of 6% extra benefit. And during the last ESMO, with subsequent follow-up for 4.5 years, the absolute gain was 7.5%. This is one of the most impressive results, actually. And if you wish to see the subgroup analysis, I was very happy to see any subgroup analysis, they do the benefit, any end stage, any pre or post-menopausal, any stage, anatomical stage of the disease. For patients with high PI, you can see the difference, 7%. For patients with low PI, again the difference, and the hazard ratio was significant. So everything went well when it came to efficacy of this regimen, actually, and it is in the guidelines. We have a lot of adverse events. Of course, you have to put that into account. But of course, the good oncologist can take care of these patients with appropriate monitoring of the adverse events and training of the patients. Bottom line, MONARCH-E is certainly a practice-changing study. It positions abemaciclib as an integral part of the treatment of patients with high risk disease according to their definition, not more than 4 or from 1 to 3 with Q3 or grade 3. The caveats: you have 2 years therapy, you have grade 3 to 50 or more, 49 versus 15%. We will not have time on the quality of life, but the quality of life was practically not really altered in this study, but still relatively short-term median follow-up till now, it is 4.5 years. The main caveat, in my opinion, is that the exact benefit of abemaciclib was not reported for patients with BRCA mutation. And the question is, does germline BRCA mutant breast cancer, they respond well to endocrine therapy? The answer, unfortunately, is no. They do not respond well to endocrine therapy. And we have learned that several years ago. That's one of the very impressive international registry for BRCA mutant carriers versus non-carriers to see the natural history of patients when they are treated. And as you can see, the higher relapse, that's the blue, that's patients with BRCA2 mutation who receive endocrine therapy adjuvantly, and that is in the same study, adjuvant hormonal therapy in patients with no BRCA mutation. You can see that the rate of recurrence was extremely higher and death was extremely higher in patients with BRCA mutations, especially those who did not receive chemotherapy. At that time, we never understood why, but several years later, we understood why. Because patients with BRCA mutation, HER2 negative, they have much higher recurrence score by NT5DX when compared to the sporadic. And there's a meta-analysis of all the studies published so far. You can see that BRCA mutations, they have 3.7-fold greater chance to be diagnosed with high-risk disease. And hence, they have poorer prognosis. And lately, the French group, they just published their data on metastatic breast cancer with treated by endocrine therapy, and they segregated the patients whether they were BRCA mutant or BRCA wild, and you can see the red curve is for the BRCA mutant. So now we started to grasp more. The question is treatment by CDK4/6 inhibitor in patients with germline mutation. Does it really work well like patients with no BRCA mutation? The answer is apparently it doesn't work as good as BRCA wild. This data from Memorial Sloan Kettering Cancer Center presented several times, and they brought a big number of breast cancer patients. You know, in Memorial, they have their own platform for genomic analysis, and they screen these patients for every gene you can dream of. Included in this study were 101 patients with BRCA2 mutation. And look at the results. They brought everybody who was treated by CDK4/6 inhibitor plus endocrine therapy, and segregated, divided them into those who were BRCA wild versus BRCA mutant. And it doesn't need you to be statistician to say that the red curve is doing poorly, which is BRCA2 mutation. Why is that? For those medical oncology interested in biology, because we have loss of function of retinoblastoma tumor suppressor in patients with BRCA2 mutation. So now we understand why. In the same year, the French group, they reported the PADA study to tell us the very same. You know, the PADA study, they had more than 1,000 patients treated by palbociclib plus letrozole. And then, in a subsequent publication, they reported patients with BRCA mutation and patients with no BRCA mutation, again, to tell us the very same story. Patients with BRCA mutation, they are in the first line, they have poorer outcome compared to BRCA wild. Bottom line, how to manage patients with BRCA mutation, germline BRCA mutation. That's why the Olympia study was very important, because actually we brought high-risk population with germline BRCA mutation. Everybody had germline BRCA mutation. I will not get too much into the classification of post-neoadjuvant treatment, but we have only less than 20% of the population with hormone receptor positive negative, and we can see that there was a very significant improvement in invasive disease survival in favor of 1 year of olaparib versus placebo after receiving chemo and radiotherapy and concomitant with endocrine therapy. For patients with hormone receptor positive, the absolute benefit was 6.7%, which was exactly the same. And the same hazard ratio, like what you have seen with abemaciclib in the monarchE. So the overall absolute gain is the same in this population, but the patient population is not the same. Importantly, in the Olympia study, there was improvement in overall survival, but of course, this is not expected to be seen in hormone receptor positive to negative, because this disease is of a slower rate of relapse compared to treatment-resistant. Again, Olympia is another practice-changing study. It could really position two things. First, you have to do BRCA mutation for all your patients, ER positive, HER2 negative, or triple-negative breast cancer. You have to do it for everybody. And the second point is in patients with BRCA mutation and high-risk population, as defined in the Olympia study, it's better you have to give olaparib for 1 year. The caveat: in the Olympia, you have a very small number of hormone receptor positive to negative, it is 325. This is a small number, actually. But because the rationale is very strong, it's extremely strong, then you can apply this to hormone receptor positive, actually. Still a rather short follow-up period for this population, but it is only 1 year rather than 2 years, which is a real advantage, and the grade 3 or more toxicity was much less than abemaciclib. Anyway, How to do in the clinic? You have to give, if your patient is BRCA mutant, HER2 negative, hormone receptor positive, you have to give olaparib. May I have just 2 minutes? Only 2. Rather than abemaciclib, not rather than abemaciclib. I will give olaparib, and if the general condition of the patient can allow, then I will give abemaciclib. I want to finish one therapy first, and because olaparib will need only 1 year, then I would like to finish it first, and then give abemaciclib. You have to discuss with your patients that we do not have data on this combination. To give the 2 drugs together, don't do that, of course, because the toxicity will be unbelievable. That's in node positive, but this ASCO we have seen in high risk node negative, because not all node negative disease, they are good disease. We have seen in the Taylor X update that patients with recurrent score of 26 or more who receive chemo plus endocrine therapy, more than 25% they relapse at 10 years, which means that this is not a good disease anymore. So again, with the PAM50 patients with high risk of recurrence, they relapse at 25% at 10 years, then they are not good respected. That's why the NATALEE study, which when it was designed, they included as well node negative, but not only all patients with node negative. They specified to have either high recurrence score by oncotype or by PAM50, or it is grade 3, or it is KI more than 26. So we have a lot of data now for node negative as well as node positive. And we have seen that there was improvement in disease-free survival. And in the subgroup analysis, you can see patients with node negative, appropriately selected, they made, again, the same benefit. Finally, be prepared for this. That's my last slide, Mr. Chairman, that immune checkpoint inhibitors are on the run now in this disease, not only triple negative. We have seen in the last ESMO that the CheckMate 7FL presented by Shireen Lloyd a few days ago, that to give neoadjuvant chemo plus or minus nivolumab, that if you add nivolumab, you can almost double the PCR rate. And more importantly, unlike this very much, in patients PD-L1 positive, which is 1/3 of the population, you increase more than that. You can reach now to 40% plus. And by this good news, I come to the end of my presentation. And thank you so much.
ثانك يو بروفيسورنا العظيم دكتور حمدي عبد العظيم. طبعا لا تعليق، بس انا هنفتح العزف دلوقتي بين حضرتك والدكتوره هبه الظواهري، دكتوره علاء قنديل، ولا ايه؟ يعني
I have to say, you are the chair lady. I'm just a speaker.
لا يا فندم،
No,
انا جايه مخصوص
good.
النهارده اسمع العزف ده النهارده. اتفضلي يا دكتوره ربنا. طبعا
Dr. Hamdi, on behalf of Ain Shams University and Department of Oncology, I'd like to thank you so much and highly appreciated your coming. أنا عارفة إنك أنا حضرتك عندك commitment في الجزائر، وحضرتك شرفتنا ونورتنا. أنا شاكرة جدا لحضرتك بالنيابة عن الاسم وعنينا كلنا في الحقيقة. My question related to our daily practice. Now, Oncotype DX, if I find in the report a reached HER2 in spite of negative, is that considered as a high risk?
Yes, if it is HER2 enriched, then treat it as HER2 enriched. We had 2 cases in our experience, only 2 cases, that it was ER positive, HER2 negative, and then we send the blocks for Oncotype, assuming it's a luminal disease, and it turned out to be a recurrence score of 70, and it was the overexpression of HER2. Then we repeated the original pathology with FISH, and it proved to be HER2 amplified. Because Oncotype will analyze what you send to them. And you will send to them the biopsy specimen that was diagnosed by our local lab as luminal disease. Because if it's not luminal, then we don't need Oncotype. Okay. So the answer is to treat her as HER2 positive.
Okay, Dr. Hamdi, please. Thank you for this very comprehensive presentation and very nice topic. But the thing which comes to our minds when we hear this data, what is the role of these agents in the further step? Meaning, what is the role of ABEMA in the metastatic setting after receiving ABEMA in the adjuvant? What is the role of PARP inhibitor if I give a PARP inhibitor in the adjuvant?
Yeah.
So if we have any data that this agent is still working in the next step when the patient progresses later on?
Yeah, you remember, it's a very valid question, actually. We are now doing two things. We are moving very good treatment, effective treatment that we are using in the metastatic phase. We are moving them to the neoadjuvant and adjuvant setting, to earlier phase. And when they succeed in the clinical trial, then we will include them in the guidelines. This means two things. First, that you will cure more patients, which is the measured benefit. So, because curability comes first. And when you pay money today to cure more patients, then you will not receive part of them as relapsing patients, and you'll pay another cost, and then the patient will die. So the argument, should we give the best we have in the adjuvant setting, neoadjuvant setting? The answer is yes. But the fireback will be when, for the bad patients who, in spite of this treatment, will relapse. So you will apply what you do when we first had. I was the only one practicing oncology at that time. When you had anthracyclines in the adjuvant, the question was, now we are giving the best chemotherapy you have in the adjuvant. What we'll do when the patients will relapse? And we knew later that, and same happened with taxane, and same happens with platinum in ovarian cancer. What we do is that you apply the general recommendations of treatment of metastatic phase. If your patient will relapse more than 1 year of any treatment, you can try your lucky stars to reintroduce the drug once again. Of course, the longer, the better. So if your patient will relapse after 2 or 3 years, after stopping the drug after 2 to 3 years, then you can reintroduce. I'm sure of that. But for the abemaciclib or olaparib, if the patient will relapse while receiving the drug, this is primary resistance of the drug, then the drug will not help you in the metastasis.
Dear Professor Hamdi Abdelazim, very excellent presentation, and if I refer to this presentation, it is a maturity onset presentation, because you started from the very basic knowledge we all know and end by the very updated 2 or 3 days ago in the ESMO. So thank you very much. أنا عايزة أشارك حضراتكم جامعة عين شمس وجامعة طبعا القاهرة، ممثلة في القصر العيني والمعهد والمنصورة والناس دي كلها. Now Professor Hamdi, BRCA mutation is very essential in triple negative K-Note 522, telling us that patients who have a residual disease, we have to explore and give
PARP inhibitor, and now the problem is we can give her Xeloda, Pempro, and then PARP, or so the sequence is a problem, but the fact is there. And you mentioned in the last two slides that BRCA mutation must be even explored in HER2 positive disease as well as human, as if we are the era of BRCA. Okay, and the PARP inhibitor will be a very backbone treatment in HER2 in breast cancer. So why not? This is my call to make a consortium for BRCA mutation in Egypt from all factories, not only to wait for a pharma to give us a carbon and do it. My call is, please, for the pathology and for prognosis and for updated trial, we would like to cooperate and do BRCA mutation in our patients.
Yes, I like the idea so much, Dr. Heba. Thank you for raising the point. And if you allow me, Dr. Lubna, we can call it enhanced declaration for BRCA mutation in Egypt, and we will take it from there. We'll have a meeting. We can have it's a very feminine team, so we will have one of the ladies to chair this committee, and we men will go under your umbrella, and we need to work together. Of course, you're right. We just published our data anyway, meta-analysis of all the studies in published in Egyptian material. The majority of publications did not came from the oncology or surgery department or even pathology. They came more from the biochemistry and laboratory medicine. So there was a tremendous heterogeneity in the rate of BRCA mutation. And we put some recommendations, including what Professor Heba mentioned now, is we need to have prospective data rather than retrospective data on BRCA mutation in Egypt. This topic was not appropriately studied in a systematic way among the Egyptians. You're right. I agree, and I'll follow it. Okay? And Shams declaration. Don't forget that.
Dr. Hamdi, one more question.
Yes, sir.
In your last presentation, you showed in the last slide the data of the CheckMate 7L trial, adding Nivo to chemotherapy as a neoadjuvant in patients with hormone-positive breast cancer. My question about how can this data will be translated into improvement? I mean, the value of the power of PCR in hormone receptor positive patient is not like that in triple negative.
Absolutely
so
right.
do you think that will be translated into improvement?
I don't know, but my hypothesis, I like the question very much because we have just seen that the prediction of better outcome in patients with PCR in hormone receptor positive to negative is not like that in triple negative. But remember, because I don't have the slide now, if you can bring me the slide مشان والله هم يعني هاخد دقيقة زيادة وحاجة. بس ساعدني قرها لي كده وهات لي نصها بالظبط. Always patients who achieve PCR, they have better prognosis. Whether it is luminal or non-luminal, حاول. Yeah. Here. PCR. At 10 years, in triple negative, you have around 10% relapse. Okay? In hormone receptor positive, at 10 years, you have around 10% relapse. But the major point is that PCR, proportion of PCR is only 11% in this disease versus 43% in the triple negative. residual cancer burden of 1, again, it can be as good as PCR. That's in the luminance. And this is individualized meta-analysis. My assumption, the best thing in immune therapy, unlike chemo, this is by chemo, unlike chemo, the durability of response with immune checkpoint inhibitors plus chemo is much longer than that of chemo alone. So my hypothesis is that we will see eventually survival improvement, but this will take time because the disease, the rate of relapse is a bit slow.
Either immunotherapy in the neoadjuvant or PARP inhibitor in the adjuvant or CDK in the adjuvant.
But immune checkpoint inhibitors in the neoadjuvant, they are far from being approved. That's only, I mean, for the sake of.
I discussed for 522. Yeah. I discussed 522.
We have again similar data, more or less not exactly similar, but similar success again with another study with pembrolizumab. Similar. So yeah. I like that.
But I ask for the approved agent for adjuvant and neoadjuvant setting. Yeah. What's your recommendation or the role of dose-dense chemotherapy for the patient in such situation with CDK4/6, with olaparib, or with immunotherapy? Who are you select for dose-dense chemotherapy?
Okay, that's a very good question. In our group, all patients, irrespective to the phenotype, not the hepatitis. All patients with triple negative and with luminal disease, we give dose dense ACE in all patients up to the age of 60. Sometimes in triple negative, we give up to the age of 65 because we have the Oxford group, they published a meta-analysis, and it's very valid meta-analysis that dose dense increases both the relapse-free survival, improve relapse-free survival, and overall survival. In the last ESMO Breast, the Italian group, they presented their 10 years data for the dose dense AC versus every 2 weeks versus 3 weeks, and they reached the same conclusion, whether it is triple negative or luminal breast cancer. So this improves event-free and overall survival. So I do that. I do that in the adjuvant or in the neoadjuvant. In the neoadjuvant, you have more space to judge what you do because you can see the response just in front of you.
So another question is you prefer in BRCA mutant patient, high risk patient, hormonal positive, HER2 negative in the adjuvant setting, the CDK4/6 or PARP inhibitor?
I do PARP inhibitor. We only have 2 patients. I'm not sure, but the end of the PARP inhibitor, we are going to discuss with her. One of them, she had 10 positive notes, so it's very high risk patient. So certainly we try to convince her that when we finish the olaparib, we may make benefit of abemaciclib. I know this is devoid of clinical study data, but till you have a clinical study on this population, probably if ever we're going to have this will take years. So you need to extrapolate in this tight area, especially in young women where they can't already see.
Please, Dr. Mohammed Alamuddin, one question. Fadal, Dr. Mohammed.
Dr. Hamdi, thank you very much for the presentation. And my question is, as I understand from the presentation, that BRCA mutation by itself is a poor predictive factor for the hormonal treatment. Yeah. So my question is, if I have a patient with luminal disease, node negative, and low KI, and I have one test to do to define if my patient would need chemo or not. So if I go for the BRCA mutation and the patient is BRCA mutant, should I just do the BRCA mutation test and then go for the chemotherapy because this patient would not respond very well to the hormonal treatment? Or
doing oncotype?
Oh yeah.
Yeah. No, because the point is, if your patient is BRCA mutant, he has a chance of being 4 times higher, 3.7 times higher than the BRCA wild. But this does not mean that her chance to be low risk is low, is 0. You get my point? You need both tests. If it is not negative, yes, I understood. If it is BRCA mutant still and not negative, still you need to go for Oncotype because not all patients with BRCA mutation they are high recurrence score by Oncotype. Not all of them.
Okay. The organizers just informed me that we are 1 hour later. I know Dr. Muhammad Sabri and a lot of you, and it's a very nice and very interesting discussion with Dr. Hamdi, of course. But they informed me that we are 1 hour later. And so thank you, Dr. Hamdi, very much.
I want to introduce our dear professor, Dr. Ala Andil, our elegant professor about management of CNS and depth management. Thank you, Hamdi, for the presentation. Bismillah ar-Rahman ar-Rahim. First, I'd like to thank Professor Lubna and her organizing committee for inviting me. طبعا شرف لي ان انا اكون موجود مع حضراتكم. And keep up the good work. Actually, meeting كل سنة أحسن من اللي قبله, more elegant. Scientific content is very strong. Actually, that was the title given to me about management of CNS and leptomeningeal metastasis in breast cancer, which is a tough subject, not only to us, but to our patients. Unfortunately, we have data, not only from the oncology database, but from the neuro-oncologist. Actually, this is a consensus that was published in the year 2022, telling us that the magnitude of the problem is increasing. And you can see that the instance from the USA for, I don't know, ممكن يكون فلتر ولا في النص ده؟ لا. Okay. About the instance of breast cancer from brain metastasis from breast cancer, the number of active prospective studies, the number of completed prospective studies, and the number of ASCO abstracts in terms of So, I mean, this is a real problem that we have with our patients with breast cancer, and it's going to be more and more. So it's the devastating, clear, and increasing common consequence of breast cancer. Unfortunately, the clinical trials that we have been used to actually did not include many of those CNS patients. Actually, they are excluded from these trials. The instance is quite relevant to the cancer subtype, being HER2, being positive, an ER positive or a triple negative. But again, you know that HER2 positive and triple negative are the most to be affected. Half of the patients with HER2 positive metastatic breast cancer, and I remember actually one figure that came from our dear Professor Hamdi Abdelazim about his own data was something like around 40%, as far as I remember, if I'm not mistaken. 25% in patients with triple negative and 10 to 15% with ER positive. However, in patients with BRCA mutant metastatic breast cancer, you have something like 50% do present with CNS metastasis. This is a huge problem. We'll be seeing more and more. Actually, these are the independent risk factors, the usual ones. We have the bad omens of younger age, negative ER, HER2 positive status, high tumor grade, and all of the factors that we know all about. Did we advance? Yes, we did advance either in the local therapy or in the systemic therapy. In the local therapy, there are improvements in the surgical techniques. Actually, the introduction of the stereotactic radiosurgery over whole brain irradiation, reduction of morbidity with better whole brain irradiation, as we will come. And last but not least is the development of CNS active HER2 targeted systemic therapies. But this, in one way, is a good thing, but in another way is a bad thing. We are very successful and more efficacious in treating patients for their extra CNS disease, especially in HER2 positive. Our patients are better controlled. They live longer to develop metastatic disease in the CNS, namely the brain or the sanctuary side that usually is not subjected to the effective treatment that we are applying in HER2 positive disease specifically. This is actually the median overall survival would be the best in the triple positive might be astonished by that, followed by the HER2 positive, thanks to the systemic therapies, and then followed by the ER positive, HER2 negative, and the worst would be the triple negative disease. So again, the molecular subtype makes a difference in the outcome of the disease. We'll start with the therapeutic approaches and in two areas. First, the HER2 positive disease, and then we'll go to the HER2 negative disease. What do we have? We have actually the so-called TKIs, and we have the monoclonal antibodies and antibody drug conjugates. And again, these are the four: lapatinib, neratinib, tucatinib, pyrotinib. And we have, for CNS disease, we have high-dose trastuzumab, intrathecal for leptomeningeal disease, and TDM1 and DXd. We start with tucatinib. Tucatinib, actually, we're very familiar right now, at least from the point of view of trials. We don't have it in hand, unfortunately, in Egypt, or mostly in the Middle East area. But in 4 years ago, in the San Antonio meeting, that was a very nice trial. This is a very early data from the HER2 selective TKI, tucatinib. And actually, you can see actually a response rate of 61%. Just look at the right-hand side of the patients who are achieving partial and complete response, stable disease. But the HER-CLIMB was the landmark trial for tucatinib. This is the trial that included tucatinib in addition to trastuzumab and capecitabine versus trastuzumab, capecitabine, and patients with metastatic HER2 positive disease. We'll be more interested in the CNS metastasis subcategory. But anyway, the data was positive for the tucatinib drug, or the tucatinib arm, progression-free survival with a hazard ratio of 0.54, 46% reduction in the risk of disease progression. Again, in terms of overall survival, 34% reduction in the risk of death. More and above, this trial included patients with active or stable brain metastasis, and this is actually not very common to see in the metastatic HER2 positive disease. And these are the numbers on the right-hand side. Now look at the intracranial activity, the CNS progression-free survival in all patients with brain metastasis. You have a very remarkable 68% reduction in the risk of CNS progression or death. This is quite remarkable by addition of tucatinib. Again, this is the overall survival in the same group of patients with brain metastasis, 42% reduction in the risk of death. And if you look and try to be more thorough, looking into the active brain metastasis or the stable brain metastasis, in the active brain metastasis, as you would expect, the benefit was very consistent in terms of progression-free survival on the left-hand side. You can see actually at 1 year, you have a 35% as opposed to 0 at 12 years. None of the patients who did not receive tucatinib and only received trastuzumab, capecitabine did go for more than a year. So it was 0. And in overall survival, 71 versus 41%, a 30% difference. This is for the active CNS metastasis. Look at the stable brain metastasis. Again, 0 at 1 year for the progression-free survival as opposed to 53%. And difference was not really remarkable in the stable brain metastasis population or subpopulation in terms of overall survival. So tucatinib did actually make a difference in this subset of patients with HER2 positive disease. By the way, those patients were treated by others anti-HER2 therapies beforehand. Those are harsh patients, not easy to treat. We're looking forward to the Bridget trial. The Bridget trial is an ongoing trial, and the idea is to add TDM1 to tucatinib. So now an antibody drug conjugate to a TKI. Hopefully, we'll see the results as soon as possible. The second TKI would be pyrotinib, in addition to capecitabine in the same HER2 positive, with a median of 18 versus 7 months difference in terms of progression-free survival, and again, a difference of 78 versus 57 in overall response rate. This is a phase 2 trial, and in the lower part of the slide, you have a phase 3 trial. Again, pyrotinib, capecitabine versus capecitabine, HER2 positive disease, and you see 11 months median progression-free survival versus only 4, something like triple improvement in progression-free survival, and overall response rate is 70% versus 16%. So this is another one TKI that we're looking forward to more data to come in and help us in treating those patients. Look at what's the amount of data we are accumulating and having in HER2 positive. Unfortunately, when we come to the HER2 negative, we don't have as much. Anyway, this is the one that we have in hand. This is the poor, I'm sorry to say, or the developing country rather than poor country, anti-HER2 therapy for CNS metastasis, which is lapatinib, capecitabine, and you've seen actually early data for that. Here you've seen the lapatinib versus capecitabine with a very convincing progression-free survival. And last but not least, neratinib. Neratinib is a pan-HER2 blocker, and you already know neratinib is there for the adjuvant therapy or the so-called extended adjuvant therapy in HER2-positive disease by the extenet therapy, but now we're talking about metastatic. So this is actually the TPCRC 022. You see that there is some response rate with the addition of neratinib to capecitabine. And these are another two trials actually on your left-hand side and your right-hand side, actually as a proof of concept that neratinib does make difference and response in the CNS metastasis in HER2-positive breast cancer. And last but not least is the NALA trial, which is neratinib plus capecitabine versus lapatinib capecitabine, which is the standard of care in countries like ours. Again, in terms of progression-free survival, there was a significant improvement for neratinib. It seems to be a stronger TKI as compared to lapatinib in this metastatic setting. Overall survival, there was a numerical difference, but not significant. What about the blood-brain barrier? This is actually the most ممكن بعد اذنك كفايه كده عشان عايز اكلمهم, right? So most importantly is the so-called blood-brain barrier. But nowadays there is another term called the blood-tumor barrier, and this is one slide on the left-hand side to tell you that trastuzumab does penetrate and reach the brain metastatic sites. It's not that we think that it's a large molecule; it does not cross. No, it's not like that, because the blood-tumor barrier might be different in those patients, and you can see. This is trastuzumab labeled with zirconium-89 and a PET-CT for the patients, and you can see on the lower part of the slide, you can see trastuzumab was well taken by these two metastatic sites. Okay, again the Patricia trial. This is the way, and again just concentrate on this: the dose leveling of trastuzumab, pertuzumab when given to patients with CNS metastasis, especially brain metastasis. You don't give the usual 3 weekly. You give trastuzumab at a dose of 6 milligrams per kilogram IV once weekly, in addition to pertuzumab at the usual dose, again 68% at 4 months and 51% at 6 months in terms of overall response rate, which is quite acceptable. Now we come to the passion of today, which is the antibody drug conjugate. What do we have in hand? We have the TDM1 on the left-hand side, the DXd or the Enhertu, and the sacituzumab Covenant. Okay? Let's go in one by one. The Camilla trial, TDM1, which is we have in hand right now in Egypt, thanks to our new protocols. And I'm always very honored to have our dear Professor Hamdi with us. When we did introduce this in our protocols to the presidential initiative, those patients are being treated with this. We have a best overall response rate of 42.9%. Still, the data from the Emilia trial compared TDM1 to lapatinib capecitabine, and we know that we have something superior in the management of this subpopulation of the patients with TDM1 over lapatinib and capecitabine. However, as things are moving very quickly, TDM1 didn't live long at that time, and it was replaced after the failure of trastuzumab Perjeta by DXd, which is Enhertu. And as far as I know from the people of AstraZeneca, that Enhertu has been already approved on Egypt, registered, but we're looking forward to the way how to use it and the guidelines in our. These are the three distance trial telling us that DXd actually was there, looking into the overall response rate till we came to the more important. This is actually the combined 1, 2, but not 3, actually telling us that we have a pool of DXd treated patients with brain metastasis. Overall response rate 27 versus 12, quite impressive. Still, we have this actually CNS progression-free survival from the same, the treated, stable, or untreated active brain metastasis. You almost always expect in the active brain metastasis to have a better response. Look at the hazard ratio on the right-hand side, 0.19. 80% of the patients do benefit from that if they have active brain metastasis. On the other left-hand side, stable brain metastasis does not mean that they don't respond. It's 0.59. So 41% improvement, which is substantial. So either the patient has a stable brain metastasis or an active brain metastasis, they do benefit by these early trials from the addition of DXd or Enhertu. Now, again, very impressive. DXd was trialed in the Destiny 03, and you see the actually hazard ratio of 0.25. This is for the whole patient group, CNS and no CNS HER2-positive disease. And actually, the difference in the two curves tells you that how DXd is more efficacious than the standard of care at that time was T-DM1. That's why TXT replaced T-DM1. And on the right-hand side, you don't need actually anything, or just look at that. Look at the response rate with TXT further T-DM1 in the lower part of the slide. This is the CNS activity now. Again, it proves that there is an intracranial activity of DXT over the other or the standard of care. And that's come actually from 3 different trials. On the left-hand side, you have the Tuxedo 1. This actually shows an overall response rate of 73%. In the middle, you have the Debra trial, response rate of 46%. And on the right-hand side, you have a very nice joint work from 3 elegant centers, Dana-Farber Cancer Institute, Duke, and MD Anderson Cancer Center, with an overall response rate of 73%. This is quite impressive and pretty assuring. Now, this is Destiny Breast 12. We're looking forward. This is accumulating patients who are treated with DXT, and this is 2 cohorts actually with absence of brain metastasis or presence of brain metastasis at baseline. We're looking forward to hear about the data of that. So what's cooking? What's in the protocols? What's in ongoing treatment trials? We are talking about T-DM1 with tucatinib, and a TKI plus ADC, neratinib plus T-DM1, the same principle, DXD plus tucatinib, or other anti-HER2 therapies, more than one combination to see what's done. Now, if you look at the NCCN guidelines, and funny enough, that's not in the breast section, by the way. As you can see, it's in the section of the central nervous system cancer. These are all options to treat patients with CNS, mainly brain metastasis. But what's only with category 1 is tucatinib, trastuzumab, capecitabine. And there are other effective regimens in this area. But remember, tucatinib, trastuzumab, capecitabine is the only category 1 in this area. So ممكن استاذن حضرتك معلش ممكن بعد اذنكم اكمل ممكن شكرا. So the HER2 negative disease we're not as successful as in the HER2 positive disease, unfortunately, because what we have in hand is not that much. All chemotherapeutic agents, endocrine therapy, and other targeted therapies like the CD46 inhibitor, abemaciclib, alpha-LC PI3K inhibitor, PARP inhibitor, and other VEGF targeting agents. What do we have? On the right-hand side, you can see that the CNS response rate is really not encouraging. 5% in abema, 18% in capecitabine, 7 to 12% in irinotecan. But the very lower part is not only for non-HER2 positive. This is all subtypes. And you can have something like 60 to 70% by the use of platinum, beva. I've seen many like that. Okay? So abemaciclib was tried actually in 3 different cohorts of patients with brain metastasis. But unfortunately, there was, yes, response rate, but it's not really substantial to tell you that you can use that. We're looking forward to the ADC, or the antibody drug conjugate, sacituzumab, in those patients. And this is actually the key eligibility criteria for this trial, S2007. Hopefully, we have results as soon as we can. PARP inhibitor has already been very well covered by our dear Professor Dr. Hamdi Abdelazim. Does make a difference in some of the patients with hazard issues that might give you a 70% response rate. However, this is a very small number of patients. You cannot conclude something out of that. Immunotherapy, where is immunotherapy? You have very scarce trials about that, and this trial actually is for all or any solid tumor, not only for breast cancer. And you have something like that, which is a median overall survival of more than 3 months. Is that acceptable or not? We're looking forward to have more data. For leptomeningeal disease, the second part, a few slides on that. This is a huge number of patients with a very decimated outcome, as you can see, at any type, HER positive, ER positive, HER2 positive, or triple negative. You're talking about tucatinib, capecitabine, trastuzumab, the HER-CLIMB regimen, with a median overall survival of 10 months. Intrathecal trastuzumab was trialed in 2 different trials, an American trial and a French trial, either weekly or 3 weekly. Very small number of patients, only 26 in here and 19 in there. And the median progression-free survival is about 6 months here, 10 months is there. It's not really very encouraging. It seems that DXD might have, because this trial actually, a phase 1 trial, is telling us that some patients can go over a year with DXD with their leptomeningeal disease. Okay, and this is abemaciclib again. I already reported on that. In the local therapy, we are already doing neurosurgical resection, stereotactic radiosurgery. Whole brain irradiation has seen a very good advancement. This is actually, I'll skip that. Yes, but the hippocampal shielding or the addition of the so-called memantine. Memantine is a drug that we use in the Alzheimer. It might help in decreasing the risk of cognitive side effects after radiation therapy to the whole brain patient if the patient needs whole brain. And these are ongoing trials in this local type therapy. You can use this actually, which is the so-called brain metastasis velocity. This is the recurrent rate of new brain metastasis after initial treatment with radiosurgery, and you come up with a score low risk, intermediate, and high risk, and you can manage your patients accordingly. So we have more than one factor in managing patients with CNS. You have the patient preference, the disease-free interval, whether the patient has systemic disease or not, how extensive is that systemic disease, how controlled is that systemic disease. These are all factors to determine should you rush into only local therapies or you have to add systemic therapies do a combined type of therapy, local therapy and systemic therapy. آسف جدا للإطالة and thank you so much.
Thank you, Professor Dr. Indeed, about your elegant presentation as usual. Concerning last slide you highlighted in the presentation, do you see that anatomical distribution of the brain mets dominating the systemic treatment? Because you see many patients with Beckley meningeal are stable over time, not like leptomeningeal. What's your opinion about this issue? Because I have many patients with Beckley meningeal on local treatment only without change of systemic treatment.
This is an excellent question. You cannot see all patients with CNS metastasis, namely brain metastasis, as exactly the same. They're not the same. As you mentioned, the anatomical distribution, how symptomatic are those patients? I mean, some patients are not that symptomatic, and some patients are very symptomatic. Some patients have extra CNS disease outside their brain or outside the spine. How extensive is that? How responding is that? How symptomatic is that? These are all, it's an art on its own to manage those patients. Unfortunately, we all hate to see patients with CNS metastasis because this is a real problem. I mean, it's not like bone or lymph nodes or so. And actually, it's very devastating for our patients. It really changes their lifestyle. But your question actually is extremely important. It's an art of medicine. We have to manage this art. Unfortunately, I don't see all of us actually doing that properly. Unfortunately, and as it is.
Thank you, Dr. Ale. And my question is, how you explain sometimes the discordance between the response between the intracranial and the extracranial part of the disease. Sometimes we have, let's say, HER2-positive disease, and we have extracranial part, and we have intracranial part. And sometimes we have a response on the extracranial part of the tumors, but for the intracranial part of the tumor is progressive. At this time, should we go for liquid biopsy to see if there is another mutations going on?
Sure. This is an excellent question, and it has to answer that. Whether the medication or the drug you're given is not crossing or reaching the intra-CNS tumor, it's one. But number two, especially for the HER2-positive disease, not for the HER2-negative, the heterogeneity. The problem of heterogeneity is a very well-known problem and actually you see this in patients with no CNS metastasis. You do a PET scan, you see very good response in that side and stable disease or even progressive disease on another side. This is mainly due to the heterogeneity.
Well, I have one question, please, because patients with HER2-positive have a story with CNS collapse, while the hormonal-positive patients have no success as HER2-positive. Do you think that if you have CNS relapse only for the patient on CD46 to change the treatment on the CNS relapse while he's responding systemically?
This is a very good question. No, you might not even, I mean, if this patient is an only CNS relapse after a long disease-free interval with no extra CNS disease, sometimes you don't give systemic therapy. You give only local therapy, whether stereotactic or surgery or whatever. Okay? But your question is very important. And you have to look in the factors that I mentioned. Do you need to add or you don't need to add? And what really bothers me is that we did not reach the same level of advancement in the non-HER2 positive disease. And we should.
Or not even to change from bulb to edema for the patient to...
Well, it could be. I mean, you can do that. I mean, I cannot tell you. It might be right. I mean, we know that Abema has, especially from the very early Monarch trial, that it has more activity or a substantial activity over the other two in the CNS metastasis or the CNS disease. But to do that or not to do that, I'm not sure. To tell you the truth. Thank you.
Thank you, Dr. Ala, about your presentation. Thank you for your attendance. Time now is Dr. Nadim Chalabi, Professor of Radiology in Shams University. We'll talk about breast imaging advances in comparison.
Good afternoon, everybody. It's an honor and pleasure to be invited to such an esteemed scientific event with esteemed colleagues and professors. Well, I've been invited to talk about, first of all, I know it's getting late and you're all very tired, and I'll be as quick and fast as possible. My talk will be about breast imaging advances and comparisons. And amazingly, a friend of mine in the States just sent me this TikTok video. I thought it might wake you up at this late afternoon. But actually, this very enthusiastic oncology doctor put that last part, as in 3D tomo and contrast enhanced mammography, will lower the scares and is an advance. All right. So imaging advances in breast are changing from 2D to 3D, and from sole morphological imaging into adding a functional behavior of the tumor cells. So in mammography, we added the tomosynthesis, which added a 3D view to the morphological imaging, and even more 3D guided stereotactic biopsy. The contrast-enhanced mammography and guidance to biopsy, and the positron emission mammography. In cross-sectional, we already have the dynamic contrast-enhanced MRI with the multi-parametric setting of it, the PET-CT, the PET-MRI, and the MRI-guided biopsy, which unfortunately is not here. In ultrasound, we have elastography, ABIS, and contrast-enhanced ultrasound. Now let me go straight to the comparisons between modalities. And our role as radiologists in combination with the work of the clinician is to choose which modality in which clinical scenario. So I'll take you through some scenarios, which is the first one is repairing an asymptomatic woman in the average screening population. We do the full field imaging by full field mammography, and we can add the DBT to have less recall rate and have a better outcome in the dense breast. However, the disadvantage is the higher radiation dose. In moderate risk ladies, we add the handheld ultrasound or the automated breast ultrasound. However, the ultrasound has a high false positive rate and operator dependent. More than 20% risk of developing breast cancer. We have to add the dynamic contrast enhanced MRI. The contrast-enhanced mammography is there, but not enough data to support its use as a regular screening tool, especially with the increased radiation dose. Now let's go into some diagnostic scenarios like pathological nipple discharge, bleeding per nipple. After the mammography and ultrasound, the dynamic contrast-enhanced MRI is really superior. And there are data that says that MRI is preferable to our old galactography technique. Breast lump diagnosis as a first diagnosis, mammography, ultrasound, and we have a 2-in-1 one-stop clinic if we do the contrast-enhanced mammography. We have the low-energy mammogram and the recombined image with the contrast, or we do a dynamic contrast-enhanced MRI. So the one-stop clinic shortens the loop. However, it needs an on-site cytologist or a pathologist on site as well. Breast cancer staging, as in the size, the dynamic contrast MRI has the best correlation with pathological size, the extent, the multiplicity, the bilaterality, the axillary lymph nodes. They are both comparable. You can do MRI or you can do contrast-enhanced mammography. As for breast inflammation and abscesses, we have the ultrasound, the MRI. I wouldn't recommend the contrast-enhanced mammography, DBT, or mammography. In problem-solving cases where there is an equivocal lesion in mammography and ultrasound, they are both comparable as well. However, please bear in mind that when you refer a patient, if we have a lesion that we can biopsy, we go for the biopsy. We do not go for an MRI, or else it will not be a problem solver. It will be a problem maker. Shall we go for sentinel lymph node biopsy or axillary lymph node dissection? It has been covered fully with Dr. Hagar and Dr. Sharif. However, we prefer doing in our institution, in our practice in Egypt, doing ultrasound and ultrasound biopsy pre-neoadjuvant chemotherapy, MRI and ultrasound post neoadjuvant chemotherapy and pre-surgery. PET MRI, PET CT are there. We still are waiting for more evidence. And there is the targeted axillary lymph node dissection when we clip the lymph node that has been biopsied and proven pathological. The post-operative follow-up surveillance of the treated breast, we have the DBT, because this one can clear the architectural distortion of the scar. And we have dynamic contrast-enhanced MRI and CIS. They are both comparable in accuracy, sensitivity, and specificity. How about the male breast? It's ultrasound, mammography, and in worst case scenario, we can do MRI. Sorry, I have a problem with this. Okay. So, which modality in which lesion? There are blind zones in mammography. So, in that case, as you can see in the image up there, we prefer doing dynamic contrast-enhanced MRI. And these are the very medial lesions in the breast and the deep ones that are closer to the chest wall. Monitoring response to neoadjuvant chemotherapy, they are both comparable. However, as was elaborated many times in the session today, triple negative and HER2 positive are very responsive to chemotherapy, and they respond in a concentric manner. So MRI is really preferable in these histochemistry, and biological type of tumors. Monitoring response in cases of masses with calcifications, in that case, we would prefer contrast-enhanced mammography, because after the chemotherapy and prior to the surgery, we can localize the calcification. Ring-enhancing lesions are better seen in MRI. Axillary nodal basins, the MRI is superior to the contrast-enhanced mammography. However, we overcome this by doing a complementary ultrasound to each and every CISM. Level 2 and 3 lymph nodes, internal mammary lymph nodes, are better seen with MRI. Extramammary signs like chest wall infection, pleural effusion, scanned upper liver, these ones are seen better with MRI. Well, in which patient and setting? This is a very basic comparison in the cost, availability, ease to analyze, time, patient and clinical preference, guidance for biopsy. Both are there universally, but in Egypt, we don't have except contrast-enhanced mammography guidance for biopsy. So let me take you through some of these clinical scenarios. This is a case 52-year-old female who was coming for screening. We found a retroareolar architectural distortion, added DBT. The architectural distortion is much elaborate, so we proceeded for a contrast-enhanced mammography. And depending on the very high negative predictive value, no enhancement was seen, so there was no lesion. And the patient followed up and she was fine. Another patient, high-risk screening patient, she's 40-year-old. However, her clinician insisted on doing a screening contrast-enhanced mammography. And these are the low-energy images, which are just like a regular mammography. In the recombined images, right upper outer, clump non-mass enhancement, heterogeneous and avid. That was suspicious. In this case, I sent her to do a contrast-enhanced mammography guided biopsy, and it returned as a PASH diagnosis. How about MRI and DCIS? And this slide is dedicated to Dr. Rida Abtaweb. I know how he has an affinity for DCIS. So whenever there is tumor angiogenesis, there is cancer, so there should be enhancement. And as you see in this small picture, there is a duct filled with malignant cells. However, there is a neovessel reaching the duct. So if there is a DCIS, it should enhance, especially if it's a high-grade DCIS, which is what we're looking for. So if no enhancement, no biologically relevant cancer, so I can say that dynamic contrast enhanced MRI has a very high negative predictive value in non-calcified lesions. How about calcifications? We'll see that in the next slide. These are meta-analyses stating that a negative supplementary MRI would potentially avoid about 81% of unnecessary stereotactic biopsy in suspicious calcification. However, this comes at the cost of missing 3.7 cancers, of which 1.6 is invasive. So what am I left with? That if my MRI is negative, I can promise the patient that she won't come back in a year with an aggressive cancer. This is an example of a case of suspicious calcification. It's just a focus of pleomorphic calcification. However, after contrast-enhanced MRI, it's a 10 centimeter clump non-mass enhancement that turned out to be a DCIS. Again, as I just mentioned in the table, that if we have a lesion that we can biopsy, we do not opt for biopsy and take the contrast study. As in this case, who was referred to me with this cluster of calcification, it was easily targeted by stereotactic biopsy, proved benign. I put a clip in the site of calcification for further reference, and the lady went without any further contrast studies needed. Another example where these calcifications, they are suspicious, highly suspicious. However, they were amenable. I could see them with ultrasound. So I took a biopsy, ultrasound guided, and I imaged the cores. They had the calcifications in there. It turned out to be a DCIS. How about evaluating response to neoadjuvant chemotherapy? Compared to MRI, PISM has equal specificity, sensitivity, and excellent performance, which may have a brighter prospect in evaluating the pathological response to neoadjuvant chemotherapy. These are examples of malignant masses and non-mass enhancement. This is a partial response of a tumor in a 48-year-old with IDC and DCIS. Another example where there were calcifications in the tumor vanished, complete PCR and complete radiological response, and the guidance for further wire insertion was with the calcification step. So as I just mentioned before, whenever we have calcification, let's follow up the neoadjuvant chemotherapy surveillance with contrast-enhanced mammography, because if we achieve complete radiological response or even partial, I can localize and bracket the calcification preoperatively for the surgeon to proceed. What other clinical scenario that we meet every day in the MDT is a pathologically proven breast cancer? We are looking for the extent, the tumor extent, multiplicity, and laterality. This is a proven IDC retroareolar. After injection of contrast media, we found that it's a single right-sided mass with intraductal extension. However, there was a small focus in the left upper outer quadrant. Second look ultrasound revealed a very small mass that was biopsied and returned a 5 millimeter left IDC. Another patient for staging, 56-year-old. She has a dense breast. She has a pathologically proven right breast mass, sent for staging. And upon contrast-enhanced mammography, we found a left small mass that was again biopsied and returned an invasive lobular carcinoma. How about the clinical scenario of a cancer of unknown primary, which we call CUP syndrome? This is a case. She's a young lady who just came to our Demirdesh clinic with a palpable lymph node. At the time she had done her mammography, only thickened skin. A junior resident did the ultrasound and said that couldn't find anything in the breast. So biopsy of the lymph node was done, and it proved adenocarcinoma of mammary origin. Contrast-enhanced mammography was done, and as you can see, there is an upper outer quadrant mass with extensive non-mass enhancement occupying the whole breast. What other clinical scenario? Nipple discharge. And I was just saying the first thing we do in nipple discharge is ultrasound. We might be lucky to find a dilated duct with a papilloma, biopsy it, and that's it. However, sometimes this is not the case. We go for MRI, and MRI, as you can see from your right-hand side, there is an extensive clump non-mass enhancement of DCIS, or I can find a dilated duct with a single papilloma. I can also find periductal mastitis with ductal enhancement or multiple papillomas. This is a case that I have met a couple of months ago. She's 33-year-old coming with bleeding per nipple, no calcification, nothing in the mammogram. The ultrasound showed only dilated ducts with inspissated secretions. So I sent her to do MRI, and these are the pictures I got. I got images of heterogeneous clump segmental non-mass enhancement. Again, I sent the patient to do vacuum-assisted biopsy, and she came back with diffuse extensive DCIS. This is a 66-year-old female coming with changes in her nipple, crust, and itching, suspected Paget. There was a bit of a thickening in the areola, and then I did the contrast-enhanced mammography and found retroareolar dispersed non-mass enhancement. I took her to the ultrasound, and in that case, I not only did a biopsy from the architecture distortion retroareolar, I also took biopsy from the thickened skin of the areola. She came back with infiltrating duct carcinoma, and the contrast-enhanced mammography with the biopsy completely changed her plan of management. How about the follow-up of the treated breast? This is a patient with left mastectomy following up with MRI. And as I said, MRI and contrast mammography are comparable. And as you can see, there is a non-mass enhancement that was biopsied and showed a right recurrence. Another follow-up recurrent surveillance of a treated breast in a 56-year-old female. It's true that the breast is fatty, but as you can see, there is a retroareolar architecture distortion. After contrast administration, the breast was free. Again, depending on the very high negative predictive value of contrast-enhanced mammography, this patient was nominated as free from recurrence. How about those recent ladies with surgical intervention? And this is a case I had a couple of days ago. She's an unfortunate lady who had invasive lobular carcinoma, and she had somehow a surgery and came back with an inflamed breast. In that case, my recommendation was to do MRI, because MRI is capable in as early as 30 days to 42 days, make the difference between granulation, inflammation, seroma, and a true malignant process. And in that case, she still had a malignant process in there, in the operative bed, and a distant focus as well. Axillary nodal evaluation in breast cancer has been extensively discussed today. However, I just want to state that the emerging evidence indicates that axillary lymph node dissection may be avoided in selected patients with node positive as well as node negative cancer. So in our institute and in the presidential campaign that is ongoing, we do ultrasound evaluation of the axilla with newly diagnosed breast cancer, whether it's clinically node positive or node negative. In pathological lymph nodes or indeterminate lymph nodes, we proceed to taking a guided core needle biopsy. In the node positive patients receiving neoadjuvant chemotherapy, we do ultrasound. However, MRI is highly indicated in these cases, and when it's followed by TAD and sentinel lymph node biopsy, it results in significant decrease in the false negative results of sentinel lymph node biopsy. I'm almost and the advantage of MRI over ultrasound, as I just mentioned, we can see the axilla on both sides. It's less operator dependent, and you can see the higher levels of the lymph nodes, level 2, 3, supraclav and internal memory. These are examples of the affected lymph nodes. Another example of a targeted axillary dissection. Whenever we have a pathological lymph node, and I'm proud to say that this is the standard of practice that we do in Ain Shams University. Actually, after the presidential campaign, we have clips. So we insert the clip not only in the mass, but also in the lymph node. We follow up the lymph node. And before the surgery, we don't have the luxury of having magnetic seeds, but we put a wire, and we try to do that on the day of the surgery because the patient, it's quite difficult for her to keep her arm for 24 hours with a wire inside. Evaluating the response to neoadjuvant chemotherapy, I'm just mentioning that for the axillary lymph node, the MRI would be more superior. So my take-home message is that the radiologist is a main pillar among the multidisciplinary team. He is responsible for choosing the best modality for the patient to achieve a tailored personalized imaging and to answer the clinical question requested in each clinical scenario. The advantages in breast imaging are vast, they are fast. There are plenty of literature on meta-analysis, on appropriateness criteria, on level of evidence. However, the clinician, the pathologist, the radiologist, and the oncologist need to work hand in hand according to the international guidelines. However, put in mind to tailor this to the local institutional resources and disease epidemiology in our country. Thank you very much. وأسف على الإطالة.
Thank you, Dr. Naveen, for this interesting presentation. And the floor is open for questions.
Thank you very much, Dr. Naveen. I really enjoyed it. Actually, I have a comment that recently we have noticed as clinicians that when you send the patient to have a mammogram, there is a conversation between the operator there and the patient, and some of them push for a biopsy without referring the patient back to the primary physician, which actually it's very new to the practice, and we totally agree that it's not acceptable. I don't know how to solve such kind of problem, but we are facing actually a problem that the patient gets scared from a junior staff who done the exam for the patient, and then when she comes back, we find out that it's not a great problem, just for follow-up. The second thing, actually, you mentioned that ultrasound is the best modality to evaluate the axillary lymph node, but we have to admit that it's operator dependent. It depends on how much does she or he has experience. And this is a very serious decision when you decide that this lymph node doesn't look suspicious, and then the patient starts neoadjuvant chemotherapy. What we used to do is that she goes for sentinel lymph node, not lymph node dissection. We don't have such opportunity to clip the lymph node at our institution, National Cancer Institute, and even in the presidential campaign, we don't have clips at the Nasser City Cancer Center, so we depend mainly on the ultrasound report, which sometimes comes away from the fact that the lymph node is involved when the pathology is done.
All right. Well, if you allow me, I think I have one answer for the two questions. And the answer is, if you trust your radiologist, you would trust her or him to take the decision of taking the biopsy, or you would trust her or his report in describing the axillary lymph node, for instance. I mean, in our practice, in my institution, we do our job, our homework in teaching the youngsters. However, in the private practice and even in our institution with our MDT, we are now reaching a consensus that if you find malignant metabarats 4 or 5 mass, it would be better to proceed for the biopsy and to save time for the patient. As for the lymph nodes, yeah, I agree that sometimes there is an overreading or underreading, and this depends on the expertise of the radiologist who is performing the exam.
I have a comment, please. I totally agree that some ultrasound sonography in the axilla may be in many circumstances operator dependent. That's why in the sound trial, they highly recommended for upfront ultrasound by high frequency ultrasound. It is a very important issue in the sonography because it's totally different high frequency ultrasound, more than 15 hertz, than the usual ultrasound. They can explore the axilla very precisely and taking the fine needle aspiration technology from the target lymph node. That's why in sound trial they build all the work on the initial high frequency ultrasound in the axilla, except that the normal sound may be of high frequency, as you said. Thank you, Dr. Nabeel, for your elegant presentation. Dr. Nabeel, one of our MD member in our department. Dr. Reda, I want to ask Dr. Nabeel.
It was the same comment. Thank you, Dr. Naveen. You are one of the main pillars of our MDT at James University. My question is nearly the same. I will tell you the results of sound trial. Gentilini published his results St. Gallen conference in March. They depend mainly on ultrasound only to detect the negativity of the lymph node, and then they decide not to do sentinel lymph node biopsy according to the results of sonar. This is his results he published in March. So do you think ultrasound is so sensitive that we depend on just ultrasound of the axilla to take this decision?
Yes, in my opinion, and according to the literature, yes, it is enough for level 1 plus or minus level 2. If we go to level 3, the supraclav and internal mammary, we need the MRI.
In cases of localized non-mass enhancement, I discussed with you previously that they are going to clipping this mass enhancement with the clips before in the future to have the positive or triple negative, because the surgery, after surgery is the main item in our management. But you are going to clipping this mass non-mass to do more than one clips or clips.
Well, actually, the problem with the non-mass enhancement is that it needs either MRI-guided clipping or conscious enhanced mammography clipping. So the only thing that we have now is conscious enhanced mammography clipping. The problem is that the conscious stays there only for 10 minutes. Sometimes all the stereotactic, whether biopsy, bracketing, wire localization, is a lengthy procedure. So we might not be able to do that in this very short window. So this remains a problem. Non-mass enhancement and conscious enhanced mammography, that has proved to be malignant. How are we going to localize this for the surgeon? It's still there.
Thank you, Dr. Nabeel, for
your presentation. Thank you very much.
For the presentation.